FRESCO-2 was a large international phase 3 clinical trial for patients that have previously received treatment with either TAS-102 or regorafenib, or they could have been exposed to both TAS-102 and regorafenib. It was meant for patients that had received at least standard of care involving irinotecan and oxaliplatin-based therapy, anti-VEGF therapy, if appropriate, and anti-EGFR therapy if appropriate. And it was a 2-to-1 randomization of to Fruquintinib, which is a selective tyrosine kinase inhibitor of VEGF receptors 1, 2, and 3 versus placebo. And this was a large international trial specifically for this analysis to determine the benefit of Fruquintinib, with the primary endpoint being overall survival. And the reason that this study was created is because in China there was a FRESCO-1 that had been conducted, which was specifically in the predominantly third-line setting. Patients would have received at least two prior lines of therapy in that setting. And because the practice patterns in China are different, where not everyone continues anti-VEGF therapy from their first line and second line treatment, which is very common here in the United States. As a result, the FRESCO-1 study was a positive study demonstrating improvement in overall survival of Fruquintinib versus placebo in that setting. And here, FRESCO-2 is basically validating that data, but also allowing even more additional prior therapy. The trial FRESCO-2 noted basically a median of at least 4 lines of therapy were provided to patients, and about 50% of patients, if I recall, had received at least prior Lonsurf or TAS-102, and then about an additional 40% of patients had been exposed to both TAS-102 and regorafenib, and only less than 10% of patients had received regorafenib alone previously. And basically, the findings noted an improvement in overall survival, which was the primary endpoint. Once again, it's a 2-to-1 randomization in favor of the investigational drug. And basically, the results were 7.4 months versus 4.8 months with a hazard ratio of 0.66. So basically, if you had received Fruquintinib in this trial, you had a 34% increased likelihood of improved overall survival versus placebo. Now, some people will criticize the fact there was a placebo arm, but please keep in mind that at the time this trial was conducted, this was also during the era of COVID. There were no other competing phase 3 trials at that time, and so it was an opportunity to provide a potential treatment option for patients that may have received, as mentioned earlier, just TAS-102 in the past, or just regorafenib in the past, or been exposed to either. So it really was a trial that allowed almost all patients to enroll, and that, I think, was the large advantage. I would say that overall, the treatment was tolerated very well. The class effect for this class of drugs is hypertension. So hypertension was the most common side effect. Some patients did get a hand-foot skin reaction. So some dryness of their hands and feet, not as severe, at least in my own experience, as what it has been seen with regorafenib, but not as light as what is commonly seen with capecitabine or Xeloda, which is a hand-foot syndrome. So it doesn't happen in all patients, but some patients may experience hand-foot skin reaction. And in my own experience personally, I've only had a couple of patients, if at all, that I've had to do any dose reduction for that reason. But overall, patients have tolerated extremely well, and very few patients discontinued treatment due to their side effects. Well, it is selective, as mentioned earlier, for VEGF receptors 1, 2, and 3, which makes it different from regorafenib, which is a multi-targeted tyrosine kinase inhibitor, and then that makes it different in that sense. And then obviously some of the other drugs that have been evaluated have not been successful in regards to their primary endpoints, such as lenvatinib, which was evaluated in LEAP 017 in combination, and it did not fulfill its primary endpoint. I would say the advantage, obviously, it's a single agent that appears to have had benefit on its own. It's given orally, daily, 3 weeks out of 4. And the FDA, for clarification, the FDA did approve this drug specifically by looking at the pooled data from both FRESCO-1 and FRESCO-2, and that's why Fruquintinib is currently approved in the third-line setting plus. There are smaller studies that have been conducted in China. There is a larger study that's been conducted here in the United States in combination with tislelizumab, which is an immune checkpoint inhibitor. A phase 2 study has been conducted, and the trial rapidly completed enrollment, and we are finalizing the data, and hopefully we'll have some results to report shortly. I think the next steps obviously are to get EMA approval and then approval in Japan. That are the next steps. And then obviously there's a lot of interest in pursuing it in other combinations. I know some other investigators or some of my colleagues are trying to consider some other investigator-initiated trials, and a lot of them are under discussion at this time. I think right now the most important thing is to get people comfortable utilizing it, getting familiar with the potential side effects, getting familiar with maybe not necessarily waiting till the very last treatment resort, right? And consider utilizing it earlier in a patient population that may derive greater benefit. Because as I mentioned earlier, FRESCO was largely done specifically in the third line setting. Some people ask me, well, how do you determine the difference between trying to make a decision between TAS-102 plus bevacizumab versus Fruquintinib? And I just kindly remind all individuals that it allows us at the end of the day to have greater options for our metastatic colorectal carcinoma patients. And obviously they have different side effects, and some patients will eventually end up being exposed regardless. And so, TAS-102 plus bevacizumab, which was largely adopted in the United States several years ago, despite the recent phase 3 Sunlight data, because only 3% of the patient population is from the US that participated in Sunlight. And that's because NCCN guidelines had approved the use of TAS-102 plus bevacizumab years ago following the phase 2 study. And so that the main side effect has been myelosuppression for that drug. And I utilize that regimen as well in a lot of my patients, because once again, we want to be able to provide as many options to our patients as possible. So some patients, though, can't receive Lonsurf because they have underlying myelosuppression just because they've been heavily pretreated. So in that case, obviously, Fruquintinib would be very appropriate for that patient population, where, you don't have to worry about myelosuppression with Fruquintinib. And then there are some patients that honestly don't want to go in every 2 weeks for their bevacizumab. So they're very interested in a oral agent that can be provided, directly, that they can administer at home, and they'd only have to go into their doctor's office once a month for a checkup. So, I would say not one regimen is necessarily better than the other regimen. They have different side effects. They offer different pros and cons. And I think at the end of the day, it's a discussion with the patient. But I think it's more important for the patient to recognize they have more treatment options. And I think that's the most important thing.